So far, we described the HIV life cycle and the mechanism of action of antiretroviral agents. Now, given a treatment-naive HIV-1 patient, recommend DHHS guideline-concordant antiretroviral therapy. Let's take a look at some reliable resources. For HIV infection and anything that's associated with HIV, such as opportunistic infections, we use in the United States the DHHS guidelines. So the DHHS stands for the Department of Health and Human Services, and their guidelines actually updated at least a couple of times a year, and they are available online. So they have several guidelines. They have one for HIV-1 for use of antiretroviral agents in HIV-1 infected adults and adolescents. They have one for pregnancy. They also have a couple on pediatrics. The focus of this presentation is on adult in HIV. They also have a guideline for pre-exposure prophylaxis and a couple on post-exposure prophylaxis, along with CDC guidelines for diagnosis of HIV. Let's take a look at diagnosis of HIV. These are the recommendations from the 2014 CDC guidelines. Since 2014, it's been recommended to use an assay that's a combination of antigen antibody, and these are antigen and antibodies from both HIV-1 and HIV-2. And if this does not test positive, so if it's non-reactive, now assuming that the patient has not had a risky behavior in the previous 15 to 20 days, then we can confidently conclude that the patient does not have HIV. And this test has a very high sensitivity and specificity. It does take some time for the body to make antibodies and for the antigen levels to increase in the plasma levels. Therefore, if someone has just been exposed to HIV, this test is unlikely to detect it. Now, if someone does test positive, we don't know if it's HIV-1 or HIV-2. So therefore, we need to do another assay, which is an antibody differentiation, to figure out if this is HIV-1, HIV-2, or both. If antibodies for HIV-1 are detected but not HIV-2, we can conclude that the patient has HIV-1. If the antibodies for HIV-1 are negative but HIV-2 is positive, we can conclude that the patient has HIV-2. If both of them are positive, then the patient actually is co-infected with HIV-1 and 2. And if neither of them test positive, now we have a problem, because initially the antigen antibody tested positive, but now we didn't find HIV-1 or 2. Now, to resolve this issue, we actually need to do nucleic acid test. A nucleic acid test is a lot more accurate because instead of antigen or antibody, it actually detects the HIV RNA. So if this tests positive, then we can conclude that the patient has HIV. And currently in the US, HIV-2 is not common. So the nucleic acid tests that are FDA approved are only for HIV-1. Now, if this patient does not test positive, we can conclude that the patient does not have HIV-1. And this is assuming that the patient did not have risky behavior in the past week. So it typically takes about 6 days for the RNA levels to go high enough for this test to actually detect it. This nucleic acid test is a qualitative test, so it basically tells you if the RNA is there or not. Regardless, when someone is tested positive, we actually need to do PCR in order to quantify the viral load. The primary reason that this algorithm exists is because these antigen antibody assays are actually more affordable than the nucleic acid test. So if you're using it for screening purposes, where majority of patients will actually be non-reactive, this is a more cost-effective way of screening people. And then people who test positive will actually end up with more tests and possibly nucleic acid tests, which are more expensive. Okay, let's take a look at HIV serology. So in this figure on the x-axis, we're looking at time in units of days after exposure to HIV. And you can see that the first few days, it's referred to as eclipse period. And it basically means that it takes a while for the HIV to replicate and actually become detectable. So what we basically use to detect HIV the soonest is the nucleic acid amplification test, which basically can detect it by day 6 to 8. whereas within the first 5 days, it's going to be undetectable. And then between days 13 and 20 is when the P24 antigen can be detected, and depending on what source you look at, you will see different numbers. So some sources say 15 to 20 days, some say 13 to 20. It's clear that around 2 to 3 weeks after exposure is when this antigen will be detected. And then it will take significantly longer for the body to make antibodies, and then those antibody tests to be detected. Now, up to 38% of new HIV infections are transmitted by people who are unaware of their HIV status. So it is important to screen people who are at risk for HIV. In fact, the 2019 USPSTF recommendations for HIV screening includes all adolescents and adults aged 15 to 65 years. And then people who are younger or older, if they have increased risk of infection, should also be screened. And of course, all pregnant persons, including those who present in labor or at delivery, whose HIV status is unknown, should be screened for HIV. So when should treatment be started in patients with HIV? Now, in the old days, it used to be that the recommendation was based on the CD4 count. So patients who had lower CD4 count, they were at higher risk of having opportunistic infections, cancer, and of course mortality. So and of course older HIV drugs were very toxic, so we would actually reserve it for more severe patients. But nowadays HIV drugs are very effective, they're very well tolerated, and we have clinical evidence that regardless of CD4 count, when we start treatment for HIV, we can actually reduce the rate of morbidity and the rate of mortality associated with HIV infection. And this mortality could be due to cardiovascular disease, it could be due to cancer, it could be due to opportunistic infection. So it actually can be significantly high. And HIV treatment can actually reduce these numbers significantly. And of course, the other issue is transmission, and we do have very good evidence that once we start treatment, HIV transmission will be significantly reduced. And this transmission could be to sexual partners, as well as vertical transmission from infected mothers to the infant. Now, the December 2019 update of the DHHS guidelines recommend initiating ART immediately. So immediately means basically the same day that the patient is diagnosed with HIV, or as soon as possible after HIV diagnosis. And this is because it has been shown to increase uptake of ART and linkage to care, as well as achieving viral suppression faster in individuals and improve the rate of virologic suppression in patients with HIV. Now, when it comes to ART, it is very important to educate patients about the benefits and considerations of ART and to address strategies to optimize adherence. So we will talk about adherence shortly, but adherence is very important. So if there is concern about patients achieving being adherent to ART, then instead of starting ART immediately, it may be more reasonable to delay it a little bit, but do it as soon as possible. So as soon as the patient has access to care and the patient is ready to adhere to ART. Interrupting ART can lead to rebound viremia, worsening of immune function, and increased morbidity and mortality. So therefore, once ART is initiated, it has to be continued with the following goals. So the goal is to maximally and durably suppress HIV RNA in the plasma, to restore and preserve the immune function in HIV patients, to reduce HIV-associated morbidity and prolong the duration and quality of survival, and prevent HIV transmission. Now, it is common that once ART is initiated, because these regimens are very effective, that the patient can actually achieve viral load reduction within the first 12 to 24 weeks of therapy. So within 12 to 24 weeks of initiating ART, the viral load should be undetectable. And recent data has shown that in patients who have a viral load of less than 200, so in general, less than 50 is considered undetectable. So even anything less than 200, studies have shown that the rate of transmission is basically non-existent. So Now we say the slogan U equals U, so undetectable equals untransmittable, and this has serious consequences when it comes to the stigma that's associated with HIV. So we're starting a new culture of U equals U, because as long as a patient is taking their ART and the viral load is undetectable, then they cannot transmit it to their partner. Now, generally there are 3 different strategies for ART regimens. The historic strategy would be the triple therapy, which basically would include 2 NRTIs or 2 nukes as the backbone plus a third agent. And the third agent can be either an integrase inhibitor or a protease inhibitor or a non-nuke. So 2 nukes plus a non-nuke. Now, in general, majority of integrase inhibitors are recommended first line, so that's why this one is green, and we'll talk more about specific agents shortly. We also have dual therapy. So dual therapy could be in 2 different ways. One is that you actually drop one of the NRTIs, and the reason we do combination therapy is that, you know, HIV has a high propensity for developing resistance, so by using combination we can basically prevent resistant development. So with the dual therapy, you basically drop one of the nukes, so you have 1 nuke plus an integrase inhibitor, which is, you know, first line. You also have 1 nuke plus protease inhibitor, which is alternative, and we'll talk about specific regimens shortly. You also have NRTI free or nuke free dual therapy. So this is basically no nuke included in the regimen. So this is basically a combination of integrase inhibitor plus a non-nuke, and the reason this is red is because it is not recommended as initial treatment. It's recommended for people who already have received treatment from another ART and achieved undetectable viral load, then they can switch to this strategy. Another non-nuke dual therapy includes integrase inhibitor plus protease inhibitor. Now, generally speaking, majority of first-line regimens that are recommended follow this rule that you need a backbone plus a third agent. So we use 2 nukes or 2 nucleotide reverse transcriptase inhibitors as a backbone plus a third agent. So it's important to have this combination in order to prevent HIV from developing resistance. And generally speaking, we have 3 backbones that are commonly used. So we have Epzicom, which is a combination of lamivudine and abacavir. We have Truvada, which is emtricitabine and tenofovir disoproxil fumarate. And we have Descovy, which is a combination of emtricitabine and tenofovir alafenamide. And I'll explain what's the difference between tenofovir disoproxil fumarate and tenofovir alafenamide shortly. Now, lamivudine and abacavir are 2 nukes that are commonly used in combination in Epzicom. So this will be 1 pill that would be used as a backbone. So if you are to use Epzicom as the backbone, you still need a third agent to go with it. Between lamivudine and abacavir, lamivudine also has activity against hepatitis B. Abacavir does not. So it's important to make sure that you are aware whether the patient also is co-infected with hepatitis B. Because, for example, if we are using something that covers hepatitis B and then later you decide to switch it to something that does not cover hepatitis B, the patient can have reactivation of hep B and possibly hep B flares, which could potentially be fatal. Now, all of these drugs in this class of NRTIs or nukes, because they actually are analogs of nucleic acids, that means that any RNA or DNA transcriptase can or polymerase can actually use this. So especially with the older NRTIs that we no longer use, they had an affinity for human mitochondrial DNA. Because of that, they were associated with lactic acidosis, and this became a black box warning, which for the entire class. So these new drugs that we use, or I should say relatively newer, compared to the drugs from the 80s, these have lower affinity for mitochondrial DNA, and therefore they are not likely to cause lactic acidosis. But regardless, the FDA has this black box warning for all NRTIs. One thing that's specific with abacavir, before anybody can be started on abacavir, we should actually do a genomic polymorphism test of HLA-B5701, and you should only start abacavir if someone tests negative for HLA-B5701. And that's because people who test positive for HLA-B5701 are at least they have a at least 50% increased risk of having fatal hypersensitivity reaction to this drug. So it's crucial to test this before starting abacavir. So that becomes one of the limitations of using abacavir, because you cannot. So if somebody tests HIV positive and you want to use this, you have to order this test, and it typically takes a few days, around a week, to come back. So it kind of delays therapy, but some patients may have no other option, so we have no choice but to test this, and then once they test negative, we can start a regimen that includes abacavir. Now, all NRTIs are renally cleared except abacavir. So abacavir is actually cleared hepatically, so you may need to dose adjust it in patients with mild hepatic dysfunction, whereas all other NRTIs actually need to be renally adjusted. So, for example, lamivudine, creatine kinase cutoff is 50. Now, as a class, all NRTIs can cause nausea, vomiting, headache, rash, and increased liver enzymes. Lamivudine specifically is very well tolerated in general, but it does cause in some patients fatigue and insomnia. Abacavir, of course, can cause hypersensitivity reaction, especially if patients have HLA-B5701. So HLA-B5701 positivity is a contraindication, and of course it can also cause fatigue. Now, when it comes to the other combinations for the backbone, we have either Truvada or Descovy. So Truvada was their first, which is a combination of emtricitabine and tenofovir disoproxil fumarate. And these two combinations, both of them cover hepatitis B, and of course they still have this lactic acidosis black box warning, which all NRTIs do. And both of them are renally cleared, so creatine kinase cutoff of 50 for these two. TAF, or tenofovir alafenamide, is a newer formulation of tenofovir, which is actually creatine kinase cutoff is lower, so you can actually still use it in some patients with CKD. Generally speaking, these drugs are very well tolerated. Emtricitabine specifically can cause hyperpigmentation. TDF can cause nephrotoxicity and bone mineral loss, and this in fact is the reason that we actually came up with a new formulation of tenofovir alafenamide, which still does have nephrotoxicity and bone mineral loss, but it's significantly less compared to TDF, and I'll explain that more. Now, note that this tenofovir does not cause bone toxicity, in the sense that it does not cause bone marrow suppression. It just causes some bone mineral loss. So this is not the same as bone mineral suppression. This just increases the risk of osteoporosis. Now let's take a look at the difference between TDF and TAF. So tenofovir itself is the actual drug. Tenofovir is the actual drug that's an analog of a nucleotide, and that's what needs to go inside the target cell to block HIV replication. The problem is when you orally take tenofovir, it's actually not absorbed. So this part is the GI tract, and when you take a pill of tenofovir, you would like it to be absorbed and go into the blood, and then the blood, in the circulation, HIV actually is inside the CD4 cell. So the target cell is the CD4 cell. That's where HIV replicates. You want this tenofovir to be absorbed into the blood, and then from the blood to go to the CD4 cell, and then find the HIV virus and block its replication. The problem is tenofovir is not absorbed. So we had to do something. We had to come up with some sort of salt formulations that increases absorption. And that's why we had TDF. So tenofovir disoproxil fumarate actually gets absorbed from the GI tract. So if you were to give 300 milligram, it gets absorbed. And then a tiny portion of what gets absorbed goes to the target cells, CD4. Okay, and that's how much we need in the CD4 in order to prevent replication of HIV. Now the problem is the majority of this tenofovir is staying in the plasma where we don't need it, and guess where it goes? It goes to the kidneys. It's gonna go to the kidneys and it's gonna cause nephrotoxicity. It's also gonna go to the bones and cause bone mineral loss, things that we do not like. So this has become a problem because patients need to be on these drugs for life, and over time this can build up, and patients will have start to have CKD, or if they already have CKD, the CKD will progress. And as we all know, as we age, we also are all susceptible to bone mineral loss due to just aging, and this will actually accelerate it. So people who have HIV and are aging and are on TDF, they actually will lose more bone mineral. So we came up with TAF, which is a different salt form. So it actually absorbs. So when you take this orally in the GI tract, it gets absorbed. Now majority of this goes into the target cell, so you get the same amount in the CD4 where you actually need it, and then a tiny portion of it stays in the blood where it's gonna go to the kidneys and it's gonna go to the bones and it's gonna cause some toxicity. But because this is a significantly lower concentration in the blood than compared to TDF, it has significantly less nephrotoxicity and bone mineral loss, and therefore we're starting to use more and more TAF compared to TDF because the efficacy is the same, because you get the exact same amount in the CD4 cell, and that's exactly why you see a huge difference in the dose. So TDF you need 300 milligram, and TAF you need 25 milligram in most regimens, unless you have like a inhibitor where you would use a 10 milligram. So if you have cobicistat in the regimen, for example, you will see 10 milligram. So which regimen should be initiated for HIV patients? So these are recommendations from DHHS guidelines that were updated in 2021. So basically here we have all the regimens that include integrase inhibitors. You can see that anytime there is a slash, that means that multiple drugs are in the same tablet, or they're co-formulated, so to speak. Whereas when you see a plus sign, that means there are two different formulations. So basically with this one you will have to take 2 tablets. Now having said that, let's take a look at recommendations. So green basically means recommended first line. So basically a triple therapy with bictegravir as the third agent with the backbone of emtricitabine and tenofovir alafenamide. That's recommended first line. You can also have dolutegravir as the third agent, plus abacavir and lamivudine as the dual nuke backbone. Now with abacavir, it is important to note that there is a HLA-B5701 test that must be performed, and it has to be negative before the patients can receive abacavir because of the risk of hypersensitivity, which can be fatal. Now with this regimen, only lamivudine is active against hepatitis B. So if someone is co-infected with HIV and hepatitis B, this regimen is not recommended because abacavir does not have activity against hep B. Next we have dolutegravir with a different backbone, so emtricitabine and tenofovir. Basically you can have Descovir or Truvada as the backbone. And lastly, More recently, we have the backbone of lamivudine plus tenofovir as a cheaper option. So these two formulations, Simduo and Temexes, these are recently available on the market as a cheaper option. So everything so far was a triple therapy. Then we have a dual therapy with a single nuke. So basically, this is the same as Triumeg. They basically dropped abacavir. So it's just dolutegravir plus lamivudine. So you basically don't have to wait for HLA-B 5701 because that becomes a barrier if you are to start ART when someone is newly diagnosed with HIV, because you have to wait for HLA-B 5701 test results to come back. So this takes care of that. So this is Dovato. And it's important to note that this Dovato can only be used if the RNA viral load is less than 500,000 copies per ml. And again, because you only have a single agent that's active against hepatitis B, it should not be used in patients who are co-infected with hepatitis B. Now, we used to have two more integrase inhibitors that used to be first line, but now they are considered alternative because we have so many other regimens that are actually, easier for patients to take. So raltegravir, because you have to take it twice a day and it's 2 pills, it's not available as a single tablet regimen. So for that reason, it's considered alternative. And then we have elvitegravir, boosted with cobicistat. So cobicistat is a pharmacokinetic booster with the backbone of emtricitabine and tenofovir. So although there are 4 drugs here, really there are 3. This is a triple therapy. You have 2 nukes and an integrase inhibitor. Cobicistat has no activity against HIV. It's just a pharmacokinetic booster. Now this is alternative, is no longer first line. It used to be first line, and the reason is because of this pharmacokinetic booster. There are a lot of drug interactions, and this is a very large pill. So for that reason, it's no longer recommended first line because we have so many other options that work perfectly. And then we have a couple of non-nuke dual therapy. So one is dolutegravir plus a non-nuke, which is rilpivirine, and then cabotegravir, which was recently approved, plus rilpivirine. And the reason these are red, because they are not recommended as initial therapy, because in order to use this, basically patients have to already receive another ART and achieve undetectable viral load, and only then they can switch to this regimen. So first, patients have to have undetectable viral load. So with Juluca, it has to be at least for 6 months, and the patient cannot have history of treatment failure or resistance. With cabotegravir, and this is actually rilpivirine, these are injectable combinations. So basically, this is to improve adherence because these are once a month injections. So basically, first the patient has to take a different ART and achieve undetectable viral load. And then for about a month, the patient will receive oral formulation of these 2 drugs just to make sure they can tolerate it. And then the patients will receive intramuscular injections of these 2 drugs on a monthly basis. And that has to be done in the doctor's office. Now, here are some other alternative regimens. So basically anything that includes protease inhibitors, they need to be boosted. And because protease inhibitors are boosted, they have a lot of drug interactions. And because we have so many other options available, these are considered alternative. Let's see. And then in the second section, we have non-nukes plus 2 nukes. So efavirenz basically is the non-nuke, and then you have 2 nukes as the backbone, emtricitabine and tenofovir. Efavirenz is no longer recommended first line. For the longest time, it used to be the drug of choice, and the reason is because of the high risk of suicide ideation and suicide attempt that has been shown with efavirenz. So for that reason, it's no longer first line because we have so many other options that are safer for patients. And then we have combination of rilpivirine is the non-nuke, and then we have 2 nukes as the backbone, emtricitabine and tenofovir. And this option is no longer first line because, in order for rilpivirine to be effective, the viral load needs to be at baseline less than 100,000 copies, and the CD4 cell has to be greater than 200. So the studies have shown that when the viral load was greater than 100,000, or if the CD4 count was less than 200, those are more severe patients, and the outcomes were basically poor with this combination. In addition, rilpivirine needs an acidic environment for absorption, so that also complicates things. So we have so many other options that are, much better when it comes to adherence for the patients and efficacy and safety. So for that reason, it's no longer treatment of choice. It's considered alternative. And more recently, we have a new non-nuke, doravirine, that's come to the market in the past couple of years. It's available as a single tablet regimen with lamivudine and tenofovir. It's also available, as a single agent, so you can combine it with any backbone that you want. And this one essentially is right now is considered alternative because of the limited data. Overall, it has a much better safety profile. And it has a high barrier to resistance. So, if you have patients with HIV resistant to rilpivirine or efavirenz, potentially doravirine could maintain activity. And then regimens to consider when, people cannot take nukes, especially abacavir because of HLA-B5701 positive test, or people who cannot take TDF or TAF because of whether they have kidney disease, advanced kidney disease, or if they have osteoporosis. These are regimens that do not include abacavir or tenofovir. So obviously Dovato, which basically has dolutegravir and lamivudine, is recommended first line. Whether people whether the reason is for people who cannot tolerate this, or even if people can tolerate it, this might be a good idea to give people Dovato to avoid some of the toxicities from these agents. There is a risk of cardiovascular disease with abacavir, and of course nephrotoxicity and bone mineral density loss with tenofovir. So Dovato is an option. And then you have a couple other options in case somebody cannot take Dovato, which Dovato is actually, has been on the market in the past couple of years, so it's fairly new. We have older agents that basically combination of protease inhibitor boosted, of course, with either an integrase inhibitor, raltegravir, or with a single nuke, lamivudine. And these are, considered alternative because of the drug interactions that you will have to deal with ritonavir, and also raltegravir twice a day could potentially reduce adherence.